Hi, my name's Matt Wilson. I'm a consultant hematologist in Glasgow, and I've been asked to answer this question today: is CNS prophylaxis still warranted in DLBCL? So thinking about this topic, we know two things about CNS relapse in diffuse large B-cell lymphoma. We know that it's rare in about 5% of patients overall, but we also know that when it does occur, the outcomes are extremely poor. And that's what makes this topic challenging, really, because it's rare. It's difficult to design studies appropriately to kind of answer the questions about prophylaxis. But because of the very poor prognosis of this event, then it really just pushes us clinicians towards always wanting to do as much as we can to prevent it. And I think to start, to mention intrathecal prophylaxis, I think this was originally used for many years, but I think now we have moved away from that, really, on the basis that there have been accumulating studies suggesting there's no benefit of intrathecal specifically, and also that's backed up by the kind of rationale that most relapses occur in the brain parenchyma in DLBCL, which wouldn't potentially be penetrated by intrathecal therapy. So high-dose methotrexate is where the field has moved to in most centers over the last few years, and it's been widely used now as CNS prophylaxis, albeit based on actually pretty poor quality evidence, mainly retrospective and small studies. And really, there's no agreement worldwide on how it should be given. Should be intercalated between cycles of R-CHOP or given at the end, how many cycles should be given, etc. And we published a large study addressing one of these questions published earlier this year, and it was a study of over 1,300 patients who'd received high-dose methotrexate, either intercalated between R-CHOP or at the end of treatment, and we showed no difference in CNS relapse rate between these two approaches. And the other important thing was that we clearly showed there was more risk of R-CHOP delay if you used intercalated methotrexate. And our other interesting finding was that in those patients who had a high risk CNS IPI, despite the use of high-dose methotrexate, the CNS relapse rate was still 9%. And that really raises this bigger question of whether it's doing anything at all. And there has now also been a large study more specifically addressing this question, and that was presented by Dr. Kat Lewis at ASH last year. And they had over 2,000 patients at high risk of CNS relapse, of which around about 400 had high-dose methotrexate, and they showed no significant reduction in CNS relapse rate with the use of high-dose methotrexate. And then that also included when they looked at some of the smaller, very high-risk subgroups. So of course, there's always caveats to these retrospective studies, but I think this is probably the largest and best data sets that we will have addressing these questions directly. And certainly, Dr. Lewis's study does actually argue strongly against the use of high-dose methotrexate for the majority of patients. So the question, I suppose, then is how do we approach this problem in 2022 in light of this? And obviously, there's no right answer, and people will interpret the data in different ways. My own practice is that I think we will become more restrictive in how we use methotrexate than previously. And at the minute, we are now going to reserve it for young and fit patients who are in the very high risk subgroups. So, for example, those with a CNS IPI 6, possibly 5, or those with renal or testicular involvement. And we will only deliver it at the end of treatment after confirmation of systemic remission. I think we do need to have a greater emphasis on screening patients at baseline for CNS disease. And that's maybe the area where we've got the most promise going forward, because there have been a number of studies investigating the use of ctDNA in the CSF as a tool for detecting occult disease at baseline. And I think really this is an exciting area and could help us really improve on our risk stratification. And of course, we then need to answer the question, what do we do when we detect this in patients at the outset? And I would argue potentially they should be getting escalated therapy with CNS penetrating agents. In summary, I don't think I have a clear answer to this question, but I think over the last year, we have now seen large data sets which at least are helping in our decision making for patients. And I think we probably are moving away from using high-dose methotrexate as extensively as before. And I think going forward, I think the emphasis does need to be on using these novel molecular techniques like ctDNA analysis to improve our risk stratification, but as well as that also on clinical trials using novel targeted agents, which might be a more effective means of reducing CNS relapse than our traditional methods.